report. At this time, I'd like to turn today's program over to Canada Health Infoway. The floor is yours.
Thank you very much, and welcome everyone. My name is Jennifer Zelmer, and just to finish up a couple of the housekeeping items today, just like to remind all participants that this session is being recorded and will be posted on Infoway's website for future use. As a reminder as well, please use the Q&A feature on the webinar screen to ask any questions at any time throughout the call. Because of the number of participants, as was said earlier, all lines are muted today. So, in terms of today's presentation, I'll be starting off with an overview of Canada's electronic medical record landscape to set the context for the presentation findings. And I'll then turn it over to Catherine Hunter. She's a consultant from PwC and worked on the study. She'll be presenting the main findings of the study today. We're also delighted to have with us Dr. Rashaad Bhyat, a family physician from Ontario. Dr. Bhyat will speak to us more about his story as a clinician working with EMRs. It's clear that this isn't just about the facts and figures, but also about how the findings apply and what the experience is on the ground in clinical practice. We'll close off with recommendations from the report and then open up the floor for questions. So the purpose of the study was to determine the current and emerging effects of implementing EMRs in community-based practice in Canada. As you may know, EMRs are used within a practice. They're computer-based patient records that typically detail patient demographics, medical and drug history, and diagnostic information. They're often also integrated with other software, for example, for billing or for scheduling. As we often heard in speaking with clinicians in preparing this study, EMRs are far more than digital paper. In fact, they can really be an integral enabler of healthcare transformation and support fundamental change in processes, practice, and workflow in clinical care. Within the scope of this study was the assessment of the effects of EMR use by family physicians and specialists, as well as their clinical and administrative colleagues in settings such as primary care, private specialist offices or clinics, community health centers, and freestanding walk-in clinics. This Pan-Canadian Benefits Evaluation Study is the fourth of its kind undertaken by Infoway. Telehealth, drug information systems, and diagnostic imaging were completed previously, and those reports are available on our website. Since 2010, Infoway has been investing with the provinces and territories as well as clinicians in EMRs. To date, these investments are supporting over 12,000 physician and nurse practitioners who are enrolled in these programs. And in addition, through a number of ambulatory EMR projects, we estimate that 25,000 clinicians will have access to clinical functionality in hospital outpatient settings. These programs also include working with our partners to achieve greater clinical value through interoperability of EMR systems with other key information, such as lab test results, diagnostic imaging, hospital reports, or medication profiles. In addition, Infoway continues to support the effective adoption of digital health through programs such as working with clinicians in training, clinical peer support networks, and other projects. And more information is available on each of these initiatives from our website. But today, we're specifically focusing on benefits evaluation. Adoption of EMRs by primary care clinicians in Canada has more than doubled between 2006 and 2012, from 23% to 56%, according to the latest data from the Commonwealth Fund survey. The adoption of EMRs by community-based specialists has also increased, from 28% of physicians in 2007 to 41% in 2010. This increase in adoption has been supported to a large extent through investment by provinces and territories, individual clinicians and their practices, and also by Infoway. Leading countries have adoption rates in primary care of over 90% of EMRs, so there continues to be room for growth in Canada. Unfortunately, similar international comparisons are not yet available for specialist physicians or nurse practitioners. Beyond the basic question of whether or not a clinician uses an EMR, it's also important to understand how that functionality is used. In Canada, as in every other country that was surveyed, the ways that individuals use their EMRs do vary. For example, almost all primary care physicians who have an EMR use it to prescribe medication, while fewer use it to, for example, order lab test results or engage in chronic disease management. This graph illustrates the percentage of use of EMR functionalities across all primary care physicians, not just those with EMRs. As you can see, use across these specific functionalities has grown since 2009. I'm now about to turn over to Catherine Hunter from PwC to walk us through the key findings of today's study. Before I do, I'd just like to remind you that you can ask questions at any time throughout the webinar using the Q&A feature in your browser. Now, Catherine, over to you.
Thank you very much, Jennifer. Over the next 15 to 20 minutes or so, what I'd like to do is walk you through an overview of our study. In particular, I'll touch upon the development of the benefits model, key study parameters and considerations as we went through this study. I'll then go into some detail around 4 key areas of benefits, and then we'll conclude with our study recommendations. So by way of introduction, the purpose of our study was to determine the current and emerging effects of implementing EMRs in community-based practices in Canada. And by emerging, we're really talking about those benefits for which there are evidence. However, there's insufficient quantifiable data to be able to extrapolate those benefits at a national level. Primary care physicians and community-based specialists were in scope, and while emerging evidence and practice were available, or highlights rather, were available for use of EMRs by nurse practitioners, quantitative data were not available on a national level, and at this time they were therefore not included in our benefit estimates. Nevertheless, we'd like to acknowledge that the current and emerging benefits reported in this study are also experienced by nurse practitioners and nursing and administrative colleagues that support community-based practices across the country. A broad body of evidence from the published and grey literature set the foundation for the development of our benefit estimates. The estimation of these national quantitative benefits was feasible for a subset of benefits where substantive evidence and data were available. In terms of the model itself for developing the benefits, it was developed by first reviewing the available literature, data from the Commonwealth Fund study and the National Physician Survey data sources, and in conducting over 20 key informant interviews with clinicians and health leaders from across Canada. This information was then used to outline a broad set of potential benefit hypotheses and associated evidence. And where robust quality evidence was available, findings were aggregated and quantified into benefit areas, and then extrapolated into the Canadian context using appropriate data sources, such as Statistics Canada or the Canadian Institute for Health Information. The benefit model was then adjusted for clinician maturity of use, using self-reported EMR use and practice variables from the Commonwealth Fund study and the National Physician Survey. And for this study, the concept of maturity use is defined as the percentage of physicians who use an EMR and can be expected to be realizing those benefits as a result of their specific functionalities and or the use of EMR data. For example, some EMR functions are used by most clinicians with EMRs, while others are only used by a subset of clinicians at this time. Based on the analysis of data, we found that maturity of use in primary care settings ranged anywhere from 3% to 56% rather, depending on the specific functionalities in question. And the maturity of use for community-based specialists versus primary care physicians was estimated slightly lower based on the National Physician Survey data. Please refer to our full report for specific maturity of use estimates for community-based specialists. And for more detail on the study overall and the approach itself, you can reference the report on Infoway's website. Moving next into study parameters and considerations, I'd like to point out a few that were particularly important to our study. The benefits estimates in our study are really a reflection of the research and evidence that is currently available to us. They are intended to be illustrative of the current emerging impacts of EMRs, and as we previously acknowledged, they are really representative of a segment of the full scope and scale of benefits that are likely being realized today. In order to address these considerations, our study team focused on those benefit areas where the most evidence was available. We used Canadian findings to the greatest extent possible. We prioritized higher quality studies, and by those we're talking about the types of studies that were undertaken through a randomized controlled trial and or for which there were pre- and post-implementation data available. We prioritized recent studies and excluded those that were considered quite dated. We established EMR adoption and usage rates of specific functionalities from the physician self-reported survey data, which is available to us for the periods 2006 to 2012. We also calculated benefits estimates from research evidence and Canadian source data. We used ranges and conservative assumptions to increase the reliability of our estimates. And lastly, we cross-referenced and validated findings with multiple sources of data and reviewed that information from across Canada with experts from the clinical and research community. So what I'd like to do here is present to you the 4 areas of benefits that we found based on our approach and the available evidence. These were really the 4 that came to the forefront. Firstly, that community-based practices experience efficiencies in workflow as staff time is redeployed. Secondly, EMR use results in health system level benefits such as the reduced numbers of duplicate tests and adverse drug events. Thirdly, the advanced use of EMRs can improve health outcomes and patient safety through preventive care and chronic disease management. And lastly, we found that EMR use supports improved interactions and communications among care team members and also between healthcare providers and their patients. The next 4 slides will go into some significant detail around each of these benefits areas. You will note that the slides are rich with information, so I'll spend some time discussing the detail around each of those and we'll walk you through that. So our first area of benefit, the community-based practices experience efficiencies and workflow as staff time is redeployed. So I'm going to start on the top left of the slide by outlining for you the estimated benefits, those that we were able to quantify. And then I'll move over into the emerging benefits, those for which there was increasing evidence, but for which benefits could not be quantified at the national level. So starting at the top left, in community-based care, an estimated benefit from the reduction or elimination of chart pulls, and by that we're talking about the manual requirement to access patient charts from a central filing area. This benefit is now valued at approximately $84 million annually. And secondly, the benefit associated with improved lab and diagnostic test management is valued at $93 million annually. For these 2 benefit areas, the annual benefit in 2012 is valued at $177 million. And if you look at the bar chart to the right of the graph, you'll see the rise in the cumulative benefits for those 2 areas, rising quite significantly from 2006 to 2012 during that particularly strong period of EMR adoption across Canada. The cumulative benefit over those 6 years for the reduction in chart pulls and improved lab and diagnostic test management is valued at $800 million. In the table on the left, you'll see the identification of 2 areas of emerging benefits. They include administrative and workflow efficiencies such as enhanced patient scheduling and billing practices among physicians. Furthermore, these emerging benefits relate also to changes in clinical processes. These are notable in the literature, but again, the available evidence did not allow us to support quantitative modeling at the national level at this time. And in addition, a recent study by McGill University and St. Mary's Health Centre examined the overall return on investment from EMR implementation in primary care. And this recent study found that 14 of 17 primary care clinics had a positive return on investment among 29 physician practices. And for those, the time to break even with their EMR investment averaged 10 months, and it ranged anywhere from 1 to 37 months. So for more detail on contributing evidence that informs the model and estimates, please see our full report. You'll see it described quite extensively there. Second benefit that I'd like to touch upon is that EMR use results in health system level benefits, such as reduced numbers of duplicate tests and adverse drug events. Starting on the left-hand side of the slide, in community-based care, the estimated benefit from reduced lab and imaging test duplicates from other care settings is valued at $99 million annually. Reduced adverse drug events, due to the improved legibility of typed versus handwritten prescriptions, is valued at $24 million in 2012. And for those two benefit areas, the 2012 benefit is valued comprehensively at $123 million. Over the 6-year period, or rather 7-year period of EMR adoption in Canada, those benefits constituted primarily of reduced lab and diagnostic imaging duplicates, totaled $584 million cumulatively. Emerging benefits were notable and include reduced duplicates where system connectivity supports the consultation of results across care setting. What we're talking about there is the ability to share and exchange data and connect with other data repositories. Emerging benefits related to a reduced number of inappropriate imaging tests are also notable in the literature. And while some robust evidence did support modeling specific examples of 6,000 fewer sinus CT scans and lumbar MRIs, evidence was unfortunately not available to inform more broad modeling across a broad scope of tests relevant to community-based care. So for more detail on this one, please do consult with our full report, as we've got a lot more description there. The third area of benefit is that the advanced use of EMRs can improve health outcomes and patient safety through preventative care and chronic disease management. You'll note that for this particular area, we have not been able to quantify financial benefits. And again, that's because of the lack of availability to model that benefit across a national basis. However, a variety of very strong quality studies have demonstrated important patient outcomes when EMRs are used effectively for chronic disease management. We've illustrated here a few of these with respect to diabetes and cancer screening. We see the following. One study reported improved care for patients with diabetes. 10.9% more patients in EMR-enabled practices achieved target HbA1c levels. 11.1% more achieved target blood pressure levels, and 18.1% more achieved target cholesterol levels. 86% of physicians in Alberta's EMR program report that their ability to manage patients' chronic diseases is improved through the use of such EMR tools as alerts, flow sheets, reminders, and goals. The list of emerging benefits that you see in this slide are considered emerging mainly because the advanced use of EMRs across community-based practice settings varies. And while there are pockets of excellence and very mature use of EMRs for these specific functionalities in Canada, and clinicians and the various provincial EMR programs are making efforts to advance the use of EMR functionalities and EMR data for practice-based population health management to drive preventive care and the proactive management of diseases. The current estimates related to the advanced use of EMRs are 3 to 18% of clinicians using EMRs for this purpose. So there we're seeing a lot of opportunity and room for growth to really advance the maturity of use, especially when it comes to improving health outcomes through preventive care and chronic disease management. In our study, you will also find some facilitators and barriers to EMR adoption and advanced use. We've outlined a number of priority areas for research to generate Canadian evidence and further validate and measure the realization of benefits in this and other benefit areas. The last benefit that I'd like to touch upon is that EMR use supports improved interactions and communications among care team members and between healthcare providers and their patients. There's a growing body of research that illustrates these improved interactions and communications. And in a moment, I'll turn it over to Dr. Bhyat, who will touch on this point and share from his clinical perspective his experiences of EMR use in community-based practice. In summary, the available evidence suggests that EMR use fosters a collaborative environment and working environment for the healthcare team, but also strong communication between patients and their healthcare providers, both on-site and remotely, and with the opportunity to enhance the patient experience and continuity of care. 96% of physicians in Alberta's EMR program report access to a summarized patient history, which supports improvements in continuity of care and also communication between healthcare providers. In 2012, Canadians whose doctors use EMRs were more likely to report that their doctor always knows important information about their medical history compared to those whose doctors use paper-based records. And now I'd like to turn it over to Dr. Bhyat for his perspective.
Thank you, Catherine. And excuse me, good afternoon, everyone. I practice in a family health group setting in suburban Ontario, and I like to think that we represent a fairly typical group practice with our physicians ranging from eager to very reluctant adopters of EMRs. Our administrative and nursing support is present, but very finite compared to what may be available in other primary care settings. We recently upgraded from an early EMR system to a newer, more robust system, and I will share some of those experiences with you today that will hopefully bring some of the study's findings to light. I'm going to focus on the latter two of the four benefit areas that Catherine mentioned. So first, with respect to the third benefit area, advanced use of EMRs can improve health outcomes and patient safety through preventative care and chronic disease management. If we look at our current EMR, it's now allowing us an easier overview of lab data, which allows me to see, for example, at a glance, what tests my patients are due or what they might be missing. And with respect to diabetes management, for example, I can now find out in a fairly easy way if, for example, an HbA1c blood test or a urine albumin creatinine ratio, ACR, is due or should be scheduled. As I mentioned, I practice in Ontario, which at the present time does not have a functioning provincial electronic health record. However, the Ontario Lab Information System recently went live, and I have access to it through my EMR in a reasonably usable manner. So when my diabetic patient says, I saw the specialist last week and we reviewed some blood work that she ordered, instead of saying, gosh, I wonder what she ordered, I haven't received a consultation report from her yet, nor was I copied on the results. So I can now say, no worries, hang on for just a minute while I check the OLIS system for the results ordered by your specialist. Here we are. Great, I see that we have no reason to reorder this test. And congratulations, I can see that your HbA1c is almost at our target of 7. Look at that downward trend and keep up the good work. So the conversations are changing. My timely access to essential information has really improved, and it helps inform my clinical decision-making for my patients. It informs my patients, both in an improved manner and in general, but in particular with respect to chronic disease management, which tends to be a little more complicated. An extremely important element of enhanced chronic disease management is the ability to produce simple reminders and tasks within our EMR that Catherine alluded to. We are able to send these out primarily to our dedicated administrative staff. If I have a patient with diabetes, for example, who is doing reasonably well and is not under specialist care, I can input reminders into the system to remind them at regular intervals about the need for blood work urine ACRs, ophthalmology visits, and immunization recommendations. It is, at the present time, it's quite time-consuming. It's not yet automated and not well supported by our particular primary care group structure, but it is leaps and bounds ahead of not being able to do it at all. The EMR also facilitates the use of chronic disease flow sheets, which enables another view of this information at a glance. I'm just cognizant of time here, but I'll just expand a bit upon how the EMR supports preventative care as well, again, as Catherine alluded to. The use of reminders has, in just 1 year, been fantastic for supporting preventative care measures. I have been sending out targeted reminders to my patients over 50 years of age to remind them about fecal occult blood testing to screen for colon cancer, reminding them about mammograms and pap smears. Within the reminders, I'm able to embed little kernels of knowledge that I hope will serve to educate both my administrative staff, who actually call the patients and speak to them, and the patients themselves who receive the reminder messages. So, for example, I might put in the reminder, a mammogram is due to screen for breast cancer every 2 years from age 50 onwards. That kind of thing adds a little added benefit, I think, for the patients and for our staff. And again, it enhances knowledge and communication within our own team. Similarly, I use reminders to inform the parents of my youngest patients when to come in for office visits for well-child visits, and of course the corresponding immunizations. So, I mean, we're about a year into it, and unfortunately I'm not doing a study on this, but I do believe that it has improved the compliance of patients coming in for those kinds of immunizations and well-child visits. And the parents really appreciate it. You know, after the first child, as many of you out there may know, it gets harder to remember multiple appointments and things, so it's nice to have that little reminder on the phone. Again, looking at the time, do we have a few more minutes? Okay. So I'll move on to how EMR use can support improved interactions and communications among the care team members and, of course, between providers and patients. As I've commented on already, communication is now formalized through the EMR messaging system and allows well-documented communication within our small team. One improvement I observed overnight was with regard to anticoagulation and management of INR lab values, which is extremely important for patients who have certain conditions such as atrial fibrillation and need to be on particular kinds of medication, anticoagulants such as warfarin. So I'm only in the office part-time, but using my EMR's remote access and messaging features, I can easily manage my INRs remotely and not fear that the walk-in physician who may be covering the test results which is the way we used to do it in the paper-based world, you know, that I don't have to worry that someone might miss that test result just by accident or because it's extremely busy or because the paper was misplaced. I don't have to worry that those results might be lost or missed. It improves patient safety in a very basic way. It also improves communication with the patient and their family members, who are often the ones who are managing the warfarin dose at home for these patients. So I believe that, you know, as interoperability expands, so too will improved communication amongst a broader range of care team members. Our physicians, and myself included, are really chomping at the bit to have more seamless, quick, paperless access to hospital reports. And I know that many physicians across the country already have those added levels of interoperability and additional information at their fingertips. So in summary, I mean, I feel that the study really reaffirms the emerging and potential benefits of EMR use in Canada, and given the relative dearth of pan-Canadian research in this area, I really believe it provides a very useful baseline and point of reference as we move forward towards greater access to necessary information and more integrated, truly team-based primary care. So I will now turn things back over to Catherine. Thank you.
Thank you very much, Dr. Bhyat. Just returning to our 4 areas of benefit, you'll recall that we've highlighted the first two that have been able to be quantified at a national level, and the latter two are areas of emerging benefit. With regard to practice efficiencies in workflow and value to the health system for which these quantitative data were available for the first two areas of benefit, we saw benefits valued at a total of $1.3 billion cumulatively since 2006. And as we have shown, emerging evidence of benefits at the practice and health system level are currently being realized in practices demonstrating advanced EMR use. Based on our study findings, I'd like to present you with 5 recommendations from the study itself. I'll walk through each of these with you. So firstly, continue to increase adoption and maturity of use in community-based settings to realize benefits. What we're really alluding to here is not only the need to put EMRs within community-based clinics, but really to advance their use. For example, ensuring that clinicians are using EMRs to their optimal functionality and able to realize the various benefits that we've alluded to, particularly those that are currently considered emerging. Secondly, to extend leading change management support and evidence-based best practices to reflect clinician and practice needs and priorities. Here we're referring to things such as peer support networks for EMR use, very focused coaching around advancing the use of various functionalities, and doing so in a way that best reflects practice's needs. Thirdly, continue to improve the accessibility and flow of information to and from community-based EMRs through enhanced connectivity and system interoperability. Here we're referring to the need to connect community-based EMRs with hospital-based systems and other databases such that there is a full reflection of patient care information available in the primary care setting. Fourthly, to broadly initiate applied approaches to population management through EMR use, using EMRs to their full capability to identify target populations in primary care practices such that those patient populations can be managed well and having their broader needs met. So for example, for diabetics or cancer patients and the like. Lastly, to address priority research areas using rigorous health services research methodologies in Canadian community-based settings to estimate the full scope of current and emerging benefits related to the optimized use of EMRs and patient outcomes. As I mentioned at the beginning of our presentation, we feel that our study is reflective of a subset of the total benefits that are likely being realized through the use of EMRs across Canada today, and certainly by undertaking additional research studies, and particularly Canadian research studies, will augment our understanding of those benefits. With the implementation of these recommendations and the ongoing engagement of clinicians, the potential for wide-ranging and transformative benefits can be further realized by providers, patients, and the healthcare system as a whole. And finally, we'd like to thank the many contributors to our study, the organizations and individuals who contributed their time, knowledge, and expertise. A particular mention goes to our advisory panel members, jurisdictional contributors, and Canada Health Infoway's internal project team. Thank you for your input and guidance, and we certainly hope that this report will support and advance the use of and benefits of EMR use in Canada. And with that, I'd like to now turn it back to Jennifer.
Great. Thank you very much, Catherine and Rashaad. And I'd now like to open the floor for questions. Just as a reminder, given that we have hundreds of participants on today's webinar, the phone lines have been muted. So please use the Q&A feature in your webinar screen to send in your questions, and our speakers will address as many as they can in the time available. Given that we've received a number of related questions, we'll also be trying to group them by topic area to address as many as we can on the call today. The first question to start with is actually a question of clarification on an earlier slide, so I'll just move back to that slide now. So the question for clarification on this slide, which was looking at the variations in terms of functionality that's in use was basically what the denominator was for this slide. And this slide is looking at the percentage of total primary care physicians in Canada who are reporting the use of these functionalities within their EMR, not the percentage of EMR users who report the use of these functionalities. So that was the first question for clarification. That leads us into a couple of questions, Catherine, that I'll send over to you, which are related to how the rates of maturity of use were applied in terms of your calculations, given that not every function was used by the full range of healthcare providers in the study. So Catherine, over to you.
Okay. Was there a particular question about that, or just in general?
We've had a couple of related questions, actually.
Okay.
So, but just as an example, given that not all physicians are using their EMRs to order lab tests electronically, yes. How does that affect your calculation of benefit areas?
Okay, certainly, thank you. What we did was we ensured that for each of the various benefit areas, we understood what the maturity of use for those would look like. And in doing so, we looked at the National Physician Survey data, the Commonwealth data, and studies as well. We were able to then understand, particularly for those emerging areas of benefit, what was the maturity of use associated with each of those. And if we look at a particular example around, and if I could pick one around the application of maturity of use for the diagnostic test, for example, we knew that this was at a lower maturity of use, and we were able to apply that. And you'll see for some areas we did not we did not quantify. And I'm sorry, I'm looking at my slide. I'm sorry, I found it. It is on slide 17. The reduction in inappropriate imaging tests with decision support. So this was an area where we had some idea of maturity of use associated with that, but we really weren't able to quantify that broadly on a Canadian level. Okay.
So Rashaad, a question for you that's come up, and that's whether you can talk about whether the use of an EMR has had an effect on the amount of patient visits you could accommodate per day.
Sure. So I have to qualify my answer by saying that I don't have a very large practice. It's about just over 500 rostered patients. So my patient volume on a daily basis is not very high compared to what some might see. But I found that it has enabled very efficient scheduling and it has allowed me to be very flexible, nimble, agile, however you want to describe it, with scheduling, and it increases my ability to communicate with the staff about scheduling. So, for example, I'm now able to implement advanced access for my patients, which basically allows less of a shorter wait time to receive an appointment. I've also been able to, so part of that involves allocating more same-day appointments. So that's, again, flexibility in the scheduling. I can also see my schedule at a glance very easily remotely. So I'm able to plan ahead and potentially ward off any issues with scheduling. For example, if I see a patient coming in on my schedule tomorrow, and I know the patient is going to need a half-an-hour visit as opposed to a standard 15-minute visit, then what I might do is send a message to the staff to adjust that. So they have 24 hours notice to do it, very simple, straightforward, and by the time I check it tomorrow, things are done, the patient has been updated. Sometimes I can do that myself, so if I see that a patient has a standard visit but they need a longer visit today, and there's room in the schedule, I can easily update it myself, and I can do it remotely. So again, all these things make the scheduling much more efficient, make life a lot easier for the patient, so that neither myself nor they feel that there's pressure for time. And that, time is always an issue in primary care and family practice, and in medicine in general, it's very unpredictable. So you can never, truly predict what's going to happen, but it does enable a much more efficient scheduling. And in theory, were I a high-volume physician, I could definitely accommodate, it would enhance my ability to accommodate more patients. I hope that answers the question.
Great. Thanks, Rashaad. And I think you may have already started to answer actually the next question, but Catherine, this one is really for you.
Okay.
Did you evaluate the effects of EMRs on patient and provider interaction?
Yes, we did. And as I mentioned, that is certainly an emerging area of benefit. We actually found rather few published studies on provider-patient interactions. However, we had quite a lot of data from surveys and also from anecdotal evidence as well that suggests that EMRs certainly change the nature of provider and patient interactions. For example, less time is spent repeating patient histories, other such information to providers. And in addition, we found that EMRs were very supportive in sharing patient educational materials as well, which was certainly deemed of great benefit.
Great, thank you very much. Next question relates to the interaction with other types of electronic systems. So can you clarify the difference between the scope of EMRs that you looked at in this study and EHRs overall? And then comment on the interaction of both EHRs and PHRs with EMRs, if that's not enough different acronyms today.
Okay, all right. I'll start with the first part of the question. So the scope of our study was really on electronic medical records that are used by community-based clinicians. And those include both primary care physicians, so your family physician, but in addition, we did look at data for community-based specialists, clinicians who do not have their clinics in hospitals, but rather in the community. So those two groups were very much in scope for our study. When we look at the type of systems that the EMRs used by community-based clinicians interact with, we're really considering those that are provincial in nature. For example, Dr. Bhyat referenced the Ontario Lab Information System that can now share information interoperably with EMRs in Ontario. We're also talking about discharge summaries that in some provinces can be shared directly with EMRs as well. What we really were not looking at are hospital-based systems that are standalone and cannot share information. With respect to PHRs, we found that this was an area for which very little evidence is available at that time. And while some clinicians and users of EMRs have an added functionality for their patients, there really remain very few in Canada, and so it was not part of the scope of our study.
Thank you, Catherine. So the next question, and actually before I go to the next question, I should just do a reminder that please use the Q&A function in the webinar functionality rather than the chat, because that will mean that the questions go into the queue that I'm looking for rather than flipping back and forth. So the next question. Ontario has approved pharmacist prescribing, and it appears that the Ministry of Health and Long-Term Care will be enhancing nurses' roles with limited prescribing capabilities. What is the assessment of these changes in prescribing practices on e-health projects and EMR adoption? I think this is a case where actually some of the information in this study can be quite helpful in understanding the kinds of areas that you would look at with any prescriber. So if you think back to the health system benefits that we're seeing in terms of the legibility of prescriptions, the ability to look at drug allergy types of interactions, regardless of who the prescriber is, those are important functionalities for them to have. And you may also be interested in looking back at the benefits evaluation study on drug information systems that was completed a couple of years ago, which looked at some broader assessments, particularly of pharmacists' views, in terms of the types of information and the impact on their work that was important. Catherine, next question back to you, which is whether in the study you differentiated between to whom the benefits accrued, so to individual practices, for example, versus the health system.
Yes, thank you. Yes, we did. And you'll see some of our headline benefit areas, certainly the first one, for example, improvements and reductions in administrative time, those benefits can certainly be considered benefits that accrue to providers and their staff, but by extension to their patients, because what we were seeing really was the redeployment of that time towards other activities, many of which are related to patient care. So moving that time spent doing administrative tasks and perhaps towards more patient care related activities. Under the second area of benefit, and certainly the third and fourth, we're seeing a broader application of those benefits to the health system and to patients alike. I mean, certainly a reduction in duplicate testing and the avoidance of adverse drug events has tremendous impact on health system costs, as what we are seeing is avoidance in hospitalization and the like. I think really the third and fourth areas, in addition to the first two, have tremendous impacts on patients and providers and the system as a whole, but unfortunately we simply weren't able to address those in a quantifiable fashion. But by improving the management of chronic diseases, that certainly will have tremendous ramifications on the health system.
Thank you very much, Catherine. We've had a couple of questions that ask whether the EMR adoption rates or other types of information like the use of specific functionalities, for example, creating prescriptions using an EMR are available at the provincial level. And the answer is that the same study that we used here, the Commonwealth Fund study, which was the basis for understanding the rates of use across Canada, was recently the fodder for a Health Council of Canada report where they did provide many breakdowns by province. So the link to that study is is available through the Health Council of Canada's website, and the detail is there. Rashaad, question for you, and whether you can talk a little bit about what advice you might give someone who was considering adopting an EMR into their practice.
Excuse me. So the best advice, I think, Jennifer, would be think about it very carefully, but proceed, talk to people who have already adopted EMRs, especially those who have had great successes with the adoption. Go into their practices and see how they do it, see how they've managed to change their workflow. I would counsel them that it's not an easy process, but it's definitely beneficial in the long run. There is initial pain, but long-term gain to be had, and essentially, I would say that if they are at depending on where they are in their professional life, it would be potentially foolish in the long term not to look at this solution, mainly because as interoperability and interconnectivity increases, we're going to reach a tipping point at which there will be so much useful information at your fingertips that it would really be difficult to practice medicine without this kind of solution in your hands. So I would say definitely consider very carefully, talk to people, and move ahead with caution.
Great, thank you very much. Catherine, next series of questions actually back to you. And they're regarding the fact that EMR functionalities may vary by vendor, for instance, and some also may affect the degree to which that may be used. And did you identify any top vendors as part of this process?
No, we did not. This study was very vendor agnostic, and frankly, in a lot of the studies that we reviewed, the vendors were simply not mentioned, and it wasn't something that we considered in the study.
Okay, thank you very much. Next question is also a variation kind of question, which is that in the literature, and in fact there's a couple questions along this line, there are different studies that report different types of results, and how did you deal with that?
Yeah. I mentioned previously in the slides that we really had a number of parameters and considerations, and that was certainly one of them. We acknowledged very early in this study that we had to look at a wide range of studies, some of which certainly did have conflicting information. Where we really focused were those studies where we felt that the evidence was the strongest and that where the studies were of the highest quality. So looking for that consistency, and we certainly collated and looked at the various evidence to come up with a mean result across those various areas. So we really did make every best effort to adopt a very balanced approach to this.
Great. Thank you very much. Then I guess this question is actually for me. Sorry about that. Question about what are our plans to repeat these studies to continue monitoring the situation on the ground? And the answer there is that this is an ongoing process for us. We have a continued program of benefits evaluation. This kind of large effort to summarize all of the studies in a given area is obviously not done every year, but we do update the results periodically, both as new literature is published and also on a more frequent basis as things may change on the ground in terms of, for example, adoption or use of various types of functionalities. And so you can see in our annual reports, for example, that we try and report back and reflect back the evolution of the previous studies that have been done, and certainly do have plans on a long-term basis of also updating the fundamental literature review and other pieces as well. In addition to that, we also work with our funded projects to complete evaluations of their work, and that obviously is yet another source of input into future benefit evaluations. Catherine, back to you, though. Does all EMR software contain the capacity for e-referral? Why are e-referrals not used more often, and what other challenges limit the widespread use of e-referrals?
Oh, very good question, and I think this really comes down to what is our definition of an e-referral system. We certainly still see primary care and community-based physicians with EMRs still using their faxes for referral purposes. However, a lot of EMR-enabled clinics do use their EMRs to share information with specialists when requesting consults. And we certainly have found, both in the studies and anecdotally, that the breadth and depth of that information, the completeness of the patient profile is certainly augmented, and we've heard from specialists that that is very highly valued. Whether or not that constitutes a bona fide e-referral system is, I think, debatable, but it's certainly something that we saw a lot of, that interaction, and I think that really supports our fourth area of benefit, too, around the interaction and communication among care teams and enhancing the continuity of care. That's one such example.
Thank you. Another question about the source of data for the percentage of Canadian physicians who are doing X or Y or Z.
Yes. A lot of that data was from the National Physician Survey, and it is self-reported. And so we looked very closely at that. Around questions were asked in that survey around specific areas of use of EMRs, and that certainly reflected our estimates and characterization of maturity of use. So, for example, we saw very advanced use and higher maturity of use around viewing results, those sorts of things, than we did for things like managing the health of patient populations and understanding those more complex areas outside of episodic care.
Next question, also for you. Did the study address privacy, confidentiality, and data security issues related to accessing personal health information through EMRs in community-based care?
No, we did not. That was not part of the scope of the study.
During your study, was there any measure of the potential change? We've got a couple of questions on this regard, actually. In provider time, either initially or over time after adoption?
We did certainly look at that, and that was one area where we relied a lot on anecdotal evidence and conversation. We really found that on the whole, providers initially experienced some disruption as they transitioned from a paper-based to an EMR-enabled environment. And you'll see also, it's somewhat reflected in the figure that I shared with you in the first area of benefit around return on investment as well, in terms of the time that it takes providers to become fully functional with their EMRs. So, I mean, many say that on average it's sort of 12 to 18 months for that time to successfully adopt and be using EMRs in the same fashion that they may have been using paper-based records previously.
Again, a cluster of questions because I'm conscious of time,
yes.
so I'm going to put them together.
Yes.
About the extent to which you looked at the cost side, and both on specific costs as well as how costs and benefits may have compared with earlier estimates that were done for a variety of sources.
Okay. Certainly the reflection of the return on investment benefit incorporated a lot of that cost. We did not get into a lot of detailed costing around specific areas of benefit, but we kept it at a much higher level around return on investment for the implementation of EMRs.
I'll give you a quick break because there's a question for me, which is what is Infoway's plan to work with jurisdictions to address the various areas that were identified as gaps in the benefits realization? And there's a number of things that we're doing both with jurisdictions and also with others. So the first thing is that our EMR and integration program is well underway, but there's still plenty more work to do, both in terms of supporting additional clinicians to adopt EMRs, but also in terms of increasing the clinical value in that use for individual clinicians or through connections with other parts of the health system as well. We also work and support clinical peer network programs in many jurisdictions, which are really ways of working one-on-one between clinicians to share their experience and hopefully help their colleagues climb that adoption curve and get to the benefits more easily and more quickly. And even back to clinicians in training. So we're also working with the faculties of medicine, nursing, and pharmacy to try and ensure that clinicians are ready to practice in this kind of environment when they graduate. So there's a number of different areas. Those are just 3 examples in which we're working, and a lot more information available in those areas on our website as well. So I think now we are back to you, Catherine. And this is probably, unfortunately, going to have to be our last question given the time, which is, did your study find any recurrent themes with respect to critical success factors for adoption?
Yes. Yes, we certainly did. And while we didn't get into a lot of detail around this in the presentation today, if you do review our full report, you'll see a lot of description around facilitators and barriers to EMR adoption. Many of you may be familiar with the various EMR programs that are in place across Canada, and certainly we've seen a lot of critical success factors that have been implemented via these programs. Things like peer-to-peer networks were certainly validated by many, but we also saw a lot of evidence to that effect in the literature as well. Another thing is to provide support beyond the initial phase of implementation, ongoing support as users advance their ability to fully adopt EMRs, and certainly when practices adopt EMRs together and adopt a very collaborative and integrated team-based approach to using EMRs, that's definitely a success factor as well.
Thank you very much, Catherine, and that wraps up our time for Q&A as I watch the seconds tick down to the end of the webinar. Unfortunately, there were a couple of questions that came in at the last minute that we weren't able to get to, but there will be, in just a second, as I change the slide, an email address up on your screen for further questions or follow-up after this session. And I also encourage you to visit the Infoway website to download a full copy of the report if you haven't already done that. And a copy of this webinar will be posted as soon as possible if you want to review it or share it with your colleagues. On behalf of Infoway, I'd like to thank Catherine and all of the PwC team for their work on this project, and to Rashaad Bhyat for taking time to participate in today's call. I should also mention that this report was developed with the support of many contributors from across the country, including our advisory panel, clinicians, researchers, and jurisdictional representatives. And I'd like to give a special thank you to all of them for their time and effort, because it would not have been possible without their help. And of course, to all of you for your time on the call today, whether you're towards the end of your day, and I should be saying good afternoon, or still slightly in the morning part of the call, depending on where you're calling from. Thank you very much for participating, and have a good day. That officially ends this webinar.
Thank you again for joining us today. This concludes today's webcast. You may now disconnect.